Okay, this is the Hamilton C1 ventilator. It's one that you'll most commonly see in Saskatoon in the RUH emergency department, and then also from adult intensive care for patient transports. It is very similar to the Hamilton G5 ventilator, which you would normally see as our base model in the adult intensive care. In terms of the setup of this ventilator, you can see the graphics, which I will go over eventually here. It has AC power cord that attaches to the wall, but also does have battery, which is why it's a ventilator that we use for transport. It has high pressure oxygen tubing that we can attach to the wall or to the oxygen tank that is located on the cart for the ventilator itself. So again, makes it very good for transport. On the other side of it, you will see it has dual limb circuit and the flow sensor attachment there. We also have the expiratory valve that is here, and the circuit will come all the way up to our patient with an HME, so a heat moisture exchanger. Therefore, it does not need a heated circuit. The patient is getting their own heat and moisture back from their breath on the next breath. The next piece is the flow sensor. We always want it pointing in this direction for our patient, and we always want the sensing lines pointing up so as they will not then accumulate condensation, which would cause an error in the machine. This filter and test lung is representing our patient, so they would not normally be pieces in this piece of equipment. Normally we would go flow sensor to the suction adapter or just to the patient elbow attached to their endotracheal tube or tracheostomy tube. Okay, now for the graphics. This is very common for the graphics that you will see displayed for the Hamilton C1 ventilator. What you're going to see is two flow waveforms moving across the screen. The most common flow waveforms that you'll see us have on here are the first one up top here. It says PAW, so P airway. So this is our pressure waveform essentially. The second one, it says flow up top, the pink lines that you're seeing here, this is our flow waveform. Your RTs will look at this and determine different settings for the patient in terms of inspiratory time and sensing abilities of the ventilator to make it most appropriate for your patient. On the left side of the screen, if you're looking at it, are the monitored values and just most common monitored values, okay? So the top one is the respiratory rate. It says F total, F meaning frequency, so how many times per minute the patient is breathing. It's currently 12, which we have it set to 12 at the moment. If your patient had effort, and I will demonstrate that, that number will increase to a higher number, whatever the patient is actually receiving for breaths. And now when I don't trigger the breath anymore, it will slowly come back down to the 12. The second setting that we have here monitored is the volume. So this is the tidal volume, exhaled volume in milliliters. This is the volume that the ventilator is receiving back into it from the patient, sensed at the flow sensor. Therefore, we know what the patient is actually getting, and we can determine if there is a leak in the system or a cuff leak on the endotracheal tube. Next monitored value here is the expired minute volume. This is simply a multiplication of the respiratory rate that the patient is actually receiving and the volume that the patient is actually receiving to give us an expired minute volume. Last setting here that we are monitoring is the peak pressure. So sorry, it's not actually a setting, it is just a monitored value. We want to keep this number as low as we possibly can in order to ensure that the patient's lungs are not receiving too much pressure, therefore causing trauma to the sensitive tissues of the lung. On the right-hand side of the screen, you'll see the actual settings. These are not monitored values, these are settings. So you will see at the top the mode that the patient is in, and I'll talk about mode in person. Next, you will see the volume on this particular mode because it's something that we set. APB CMV is a very common mode that you will see in emergency. Next, you will see the PEEP, so positive end expiratory pressure, commonly set at 5, but will be higher often in patients who require a little bit more recruitment and oxygenation. And lastly, the oxygen. So that's their fraction of inspired oxygen in the percentage measurement. The next items that you're going to see are controls and alarms. Those are things that your respiratory therapist will modify for you. Along the bottom of the screen here, the major tab that you're going to be using as nursing would be the monitoring tab. So if you touch the monitoring tab, it has multiple different tabs underneath it. So for your monitoring records, if you are monitoring more than just the 4 values that we had up, you can search through these tabs. Don't worry, it will not change anything for the settings of your patient, and you can record everything that you might need to. And then just touch the X to get out of it. I should say it is a touch screen, but if you needed to, and sometimes the touch screen isn't as sensitive depending on if your fingers are cold, you can always rotate through with the knob, and it would be, once it's yellow around the item that you would like, press, turn, and confirm. If you were to press and turn and not confirm, the value after a few seconds will default back to its original value. So this is the Hamilton C1 ventilator. So on the Hamilton medical devices, there are 2 different types of alarms. I'm going to be showing them with the Hamilton T1 ventilator. The 2 different types of alarms are low priority and high priority alarms. Low priority alarms, as they sound, don't necessarily need to be tended to immediately, but best advice would be anytime an alarm is happening, please look at your patient and make sure they are still getting appropriate chest rise, check for saturations, always check your patient. If something is wrong, you can always take them off the ventilator and provide bag mask ventilation or bag through the endotracheal or tracheostomy tube. The low priority alarms, how they will look and sound, there is a bar across the top of the ventilator, both for the T1 and C1. This is going to look identical. This bar across is going to flash yellow. Additionally, in the alert section at the top of your touch screen, what you will see is a yellow bar with writing inside of it indicating the type of alarm that it is. Lastly, what you're going to see is the value that is an issue will, instead of being in white writing, will now be in yellow writing. So consistent in terms of the yellow to indicate that it is a low priority alarm. Rather than for a high priority alarm, the bar will flash red at the top. The bar that you will see on the display will be red with writing inside, again indicating the type of alarm that it is, and the value that is an issue will also be then written in red rather than white. I will now demonstrate an example of a low priority alarm. A common one that we'll see is tidal volume low or potentially minute volume low. This occurs if you potentially have a cuff leak around your endotracheal or tracheostomy tube, if your patient is waking or the sedation is inconsistent and they are therefore taking some small breaths and some large breaths. Just 2 examples of when this might happen. All right, I will now try to show a low volume alarm. And there it is. You can see the yellow bar at the top, the yellow bar indicating tidal volume low, and our tidal volume that's located here in yellow now. Once the alarm has been fixed or the issue has been fixed, the ventilator will correct itself and come back to normal ventilation as it was previously set. And there we go. It's coming back to normal over a few breaths. As a reminder, you can use the silence button while you are troubleshooting. Press the silence once for 2 minutes of silence while you troubleshoot your alarm. The next type of alarm, and I'm just going to clear my silencing, the next type of alarm is that high pressure alarm. Typically you're going to see this when your patient coughs, if they're waking from sedation, again, and their breathing is very inconsistent, if they're bearing down against the breath of the ventilator. Just some examples of when you might see this. So I will now try to demonstrate a high pressure alarm. And this is a high pressure alarm. You can see our waveforms have changed drastically, and this is very common with a cough in your patient. Once the issue has been fixed, or say the patient stops coughing, again, the ventilator will correct itself after over a few breaths back to whatever normal ventilation was based on the mode prior to the alarm.